Hi, welcome to Therapy Ed's online office hours regarding anatomy and physiology of communication and swallowing with me, Dr. Lolly Vaughan-Robinson. All right, the copyright compliance, our logistics and focus for the online session, the live office hours, where we'll review questions and I'll answer questions. Our outline for tonight, we'll talk about the anatomy and physiology basics, the basic terminology. We'll do a quick neuro review. We'll talk about each of the systems involved in communication and swallowing. So the respiratory system, the laryngeal system, the physiology of it for voice and swallowing, articulatory and resonatory system, and then the hearing system if we have time. And these are some selected references. All right, so here are our speech subsystems. Right, we've got on the bottom, we've got our respiratory system. We've got our respiratory system here with our lungs and trachea and bronchial tubes, with the diaphragm down here below stretching throughout the thoracic cavity, actually separating the thoracic and the abdominal cavities. But it goes from one side of your rib cage to the other and front to back. So it's a pretty broad muscle, and it's the major muscle of respiration. Up here in the green, we have the phonatory system, which is comprised of your larynx, and that's your vibratory sound source. And then up here in the orange, we have your resonatory system, which is your pharyngeal and nasal and oral cavities. And then our articulatory system is, of course, our sound shape, our tongues, our teeth, our lips, etc., and how we shape the sounds and join them together, so co-articulation as well. And then I'm going to add a couple that aren't actually on this, drawn on the picture, but they're critical nonetheless. Of course, we have also our hearing mechanism. That's how we process the sounds around us, and it's how we know when we stick our feet in our mouth. We got to listen to ourselves and get that feedback. And then also we have the nervous system, right? It's our central processor and controller. It's what sends out the messages to move the muscles for us to speak. And then, of course, it receives the sound and perceives it as the word cat or dog or fire engine siren or, your favorite song on the radio. Okay, so this is just a review of that picture. I can't reverse the slides I just learned a minute ago, so hope you can visualize that picture or follow along in the book. There's a similar picture in the book. Again, nervous system is the central source and processor for all outgoing and incoming messages. It's comprised of the central nervous system, peripheral nervous system, and autonomic nervous system. Central nervous system is comprised of your brain and spinal cord. Your peripheral nervous system is your cranial nerves and spinal nerves. And then your autonomic nervous system is made up of your parasympathetic system and your sympathetic system, with your sympathetic system being fight or flight and the parasympathetic system being your homeostasis or zen-seeking portion of your nervous system. The respiratory system, we said, is our power source. So if you see a child about to run in the road, if you think about yelling no, the first thing you got to do is take a big breath. No! Even if you just imagine yourself, you do that quick inhalation to get that big breath so you can belt it out to keep that kid from danger. Then we have the phonatory system, the vibratory sound source. So you can always put your hand on your neck if you're not sure. But the vibration, if you just say zzz versus ss, you can feel that vibration, and that vibration is coming from the vocal folds in your larynx. And then we have our articulatory and resonatory systems that shape the sounds that we say, with the tongue being the major articulator, our lips, our teeth, our palates, nose, etc. And of course, we said our resonatory system is largely our cavities, the pharyngeal cavities, nasal cavities, and oral cavities. And then last but not least, our auditory system, which is the sound receiver for all environmental sound, and of course our hearing mechanism. All right, so basic definitions. Anatomy is the structure of organisms, their names, and their locations. So, we'll be talking about the larynx, and we'll be saying that the larynx is what most people know as the voice box, and it is inferior to the mandible and superior to the trachea. So we're talking about the name of the structure, and we're talking about its relation to the structures around it. So that's the nomenclature, and then, of course, the location. And physiology is the science dealing with the function of living organisms and their parts. So when we're talking about physiology, it's how that larynx works, how it creates voice, or how it contributes to the swallowing and airway protection. And then lastly, we have histology, which is the study of cell structure and tissue. We're not going to camp out there a whole lot. We will talk about epithelial tissue and then, of course, nervous tissue. All right, so let's talk about planes, because sometimes there are images in the praxis. So the coronal plane is like a morbid crown, if you want to think about it like that. But if we set this morbid crown on their head, and it would divide the body into front and back halves. Okay, so this plane here divides the body into front and back halves. Then we have the sagittal plane, which is kind of like riding a really painful saddle, but it divides the body into right and left halves. Okay, and then lastly we have the transverse plane. Let's see what color. Let's do purple. That divides the body into top and bottom halves. So you think about magic shows where they put a person in a box and stick a piece of metal in there and cut them in half. That would be the transverse plane. All right, our basic tissue types. Okay, so if you think about nature, any critter, but especially the human critter, we start out, we have cells, and then a clump of cells makes up some tissue, and those can be differentiated, and then the clumps of tissue that work together become organs, and the organs that work together become a system, and then the systems are all housed together to help the organism or the body move and function, right? So tissue, again, is an aggregate of cells with the same functional unit, and we have 4 basic types. We have epithelial tissue, connective tissue, muscular tissue, and nervous tissue. Epithelia, of course, is your skin and the linings of cavities, so that's very critical for the mouth and the nose and the throat, larynx, etc. And if you've had any classes or work with head and neck cancer patients, one of the primary cancers that we deal with is squamous cell carcinoma, which is an type of epithelial tissue. And then we have the 3 types of muscle. Cardiac muscle, which is in the middle on the picture on the bottom, but that's the muscle specific to the heart. We have smooth muscle, which is largely in the intestines, and that is involuntary movement. You don't have to think about digesting your food, thank God, because we've already got enough to think about in our day, especially in grad school and preparing for the praxis. And then striated muscle tissue, which is ropier, and that's the top, but that's the type of muscle tissue in volitional motor control. So your skeletal muscles, and then the muscles of articulation, the majority of the muscles for swallowing, they're all going to be, till we get down to the esophagus. That's why I said that. Because in the esophagus we blend, in the upper part it's blended volitional, or the striated muscle and smooth muscle, and then as we go farther down the esophagus it becomes smooth. I apologize. Okay, because it's involuntary. All right, basic components of the nervous system. So we're talking about histology a second, the study of cell structure. So with neurons we have the dendrites, which are the leafy, bushy branches off the cell body, and they receive the messages. We have the body of the neuron, which houses the nucleus, and then we have the axon hillock, which is getting more and more attention lately, because that's where the neural integration takes place, whether to send the message on or inhibit it. And then we have the axon, of course. And then at the very, very bottom, we have the telodendria. And we always remember this, because the telodendria tell the T. They're the ones that send the message, right? So the telodendria tell the T. T-time with the telodendria, if you want to think about it that way. And we do have different types of neurons. The ones we're most concerned with speech, especially the motor aspects of speech, are the multipolar neurons. That's what comprises the corticospinal tract, which controls most of the speech muscles. We have glial cells that are responsible for support of the neurons, so they're kind of the entourage for the celebrity neurons, but they do waste removal, they contribute to the blood-brain barrier, and much more. And then lots of bundles of neurons create a ganglia and then ultimately a nerve. All right. This shows the action potential. It's probably been a minute since you took your initial neuro class. But remember that a neuron doesn't fire all the time. It has to be stimulated enough. It has to go from its resting potential to the action potential. So we're talking microvolts, right? We're talking really small changes in voltage. But that resting potential's down below negative 60 microvolts. And then we get stimulation, we get enough stimulation, that threshold starts to rise, and finally we reach the membrane potential, where we've achieved that action potential, and the sodium rushes in, and we have a big party, lots of positivity going on in the neuron, and then it's time to shut it down, kick the sodium out, and then it gets so negative in the neuron that the cell becomes hyperpolarized, and the cell can't fire. That's absolute refractory period. And then as it is returning back to its resting potential, that's considered the relative refractory period. And it can fire there if it receives extra stimulation to push it to action potential. Okay, so neurulation is the differentiation of ectodermal cells in the cells of the nervous system. I apologize. And this shows you the cross-section of an early embryo animation. So, it started out as a zygote, and we had some multiplication of some cells, and then ultimately we're starting to form specialized tissue. And we start with the ectoderm, the mesoderm is the middle layer, and the endoderm. And you can see that ectoderm pinches off into two parts. And the little circle here, right here, that pinches off becomes the neural tube. And that's what forms. And then as it continues to grow and develop, it becomes the prosencephalon, the mesencephalon, and the rhombencephalon. So this is a table of the same animation. So the neural tube becomes even more specialized. We have the endoderm, the mesoderm, and the ectoderm, with the ectoderm ultimately becoming the central nervous system. So the prosencephalon, remember that's going to be the superior most portion of the neural tube, and that's what we actually think of as the brain, because it's comprised of your telencephalon and your diencephalon. So we have the cerebrum, your limbic system, basal ganglia, and your diencephalon. Your cerebrum, that's your higher functions, your filters, your language, memory, integrates sensory motor functions. Limbic system is important for emotional regulation, processing emotions, creating emotions, and then also memory, very critical to memory. And then your basal ganglia regulates motor movements, especially background movements and muscle tone. And the diencephalon is made up of your thalamus, your thalamic nuclei, hypothalamus, epithalamus, and subthalamus, with the thalamus being the biggest portion, and it's the central relay station for everything coming in, going out of the cerebral cortex. The mesencephalon, we have the midbrain, so we have a lot of auditory and visual reflexes there. If you remember, that's where your colliculi are, superior and inferior. Maintains cortical arousal, and so that's a critical piece when we're talking about decerebrate, decorticate posturing in patients that are in some degree of coma. And in the midbrain, we have some cranial nerve nuclei and their nerves exiting there. And then the metencephalon is the pons and cerebellum. The pons is largely a bridge, and that's where that name comes from. If you know French or Spanish, it's very similar to the word P-O-N-T is bridge in French, and so that's the Latin derivative. But it houses cranial nerve nuclei 5, 6, 7, and 8. And then the cerebellum, remember, hangs off the back of the brainstem, forms the posterior wall of the fourth ventricle, and it regulates coordination of skilled movement. So that's where our diodos come in, as testing cerebellar function. And then the myelencephalon is, of course, your medulla, and it regulates respiration, phonation, heartbeat, blood pressure, kind of important, regulates reflexes, and it's largely where the biggest portion of the corticospinal tract decussates, and houses cranial nerves 9, 10, 11, and 12. So hypoglossal and vagus both exit there, critical for speech and swallowing. All right, our cortical cell layers, bunches of neurons form the cortical tissue, and the different types of neurons and the molecular layers have different densities throughout the cortex. And so in your odd layers, so the layer 1 and layer 3 and 5 are more motoric and layers, and then the sensory areas have denser tissue, denser layers in layers 2 and 4. They're a little more detailed there if you want to go and review those. All right, so just to review 4 main lobes of the brain, we've got the frontal lobe here, right, with motor in the front. You got your motor strip, you got your premotor cortex, you've got your supplementary motor cortex, you got Broca's area down here, right? So all these areas are very motorically based. Then you've got your prefrontal cortex for your higher level thought processes, your executive planning, all that kind of thing. And the parietal lobe, this is bodily sensation, proprioception. And then in the left hemisphere, which we're looking at, got our areas for reading and writing along that angular gyrus. Then we've got the temporal lobe, very critical to auditory processing. We'll see that here in a second. We've got Heschel's gyrus and Wernicke's area. And then last but not least, we have what color can I use? We have the occipital lobe for visual processing. And over here on the right, we've taken the motor strip here from the back of the frontal lobe, and they've turned it sideways, and you can see representation of all the muscle groups, and that's what creates the movement in our bodies. And you'll notice that the tongue and the lips are much larger than the fingers, relatively speaking, than the legs and arms. And that's because fine motor movement takes more neural representation, so they're represented bigger on the homunculus. And in the sensory homunculus, you'll notice you have a structure on the sensory homunculus that you don't have on the motor homunculus, because your teeth, we can't voluntarily move them independently, right? We have to use our fingers to wiggle a tooth. So there's no muscle fibers in teeth, just sensory, right? Because some of you may be sensitive to hot and cold, and so you're very aware how sensitive your teeth are. All right, so Brodmann's area is associative speech and language. You'll see here, we just talked about the motor strip, and it's denoted here in the green with the number 4. And then the primary somatosensory cortex, areas 3, 1, and 2, along that postcentral gyrus in the parietal lobe. We have Broca's area over here, 44 and 45 in the frontal lobe. It's important for semantics and the voluntary motor planning aspects of speech. And then down here in the temporal lobe, we have Brodmann's areas 41 and 42, so that's getting into Heschel's gyrus, the primary auditory cortex, and that's where, we've got a 1-to-1 ratio with the hair cells in the cochlea and Heschel's gyrus, the neurons in Heschel's gyrus. So they're very Just like your cochlea is tonotopically organized, Heschel's gyrus, or that primary auditory cortex, is also tonotopically organized, and it only fires for that specific frequency. And then Brodmann's area 22 is Wernicke's, where we put meaning to the sounds we hear. In the left hemisphere, it's dedicated more towards speech and language sounds. And then in the back, we have Brodmann's area 17, which is the primary visual cortex, and the occipital lobe. Here we've got the limbic system. A lot of times it gets left out, but it is critical, and especially for memory and emotional processing and emotional regulation. Okay, so projection fibers are going to project. So if you think about a movie theater, the projector is way in the back of the theater, and then the screen is way in the front of the theater. So they've got to project it. They've got to get that image a long way, okay? Well, same thing with our muscle fibers, okay? The brain has to get the message from all the way at the top of your head along that motor strip down to the muscles in your fingers and toes. And so the way it does that is with projection fibers. And so this picture kind of demonstrates how the message travels from the neurons on the primary motor cortex, bottleneck through the internal capsule, and then we decussate in the medulla, and then we travel down the lateral corticospinal tract, and then out the ventral horn of the spinal cord to the lower motor neuron, so the nerve and the neuromuscular junction. Fire on that nerve, and that muscle twitches, and we either kick the doctor when he hits us in the knee, or maybe you restrain yourself. Got to overcome that reflex. All right, so our descending pathways are motor. So let me write that down real quick for you. So our descending pathways are our motor pathways or our efferent pathways, right? I know that's not the way to pronounce it, but I know I have an accent, and so I say efferent to distinguish efferent and afferent because it's hard to distinguish the way I talk, so I apologize. So it's our motor or our efferent or efferent pathways, right? Okay, so we do have descending pathways in the anterior portions of the spinal cord and the lateral portions of the spinal cord. So I always tell my students to remember that the sensory motor system in the body is set up kind of like a mullet or a car, okay? So the motor is in the front and sensory in the back. You think about chills running up your spine. That's a sensation, right? Or if you think about a car, the motor makes you go, and everybody else is enjoying the song in the car. It's more sensory, right? So our anterior pathways, we've got the anterior corticospinal tract, which is only 20% of the motor fibers, but they're undecussated. We have the tectospinal tract and the anterior reticulospinal tract. Those two last two are really important for the indirect activation pathway. And then our lateral pathways, we have the lateral corticospinal tract. That's the major one that we think of as being the corticospinal tract. And that's the decussated motor fibers, 80% under contralateral control. So that means that the left motor strip controls your right leg, your right hand, etc. And then the rubrospinal and lateral reticulospinal, again, contribute to the indirect activation pathway to give us precision of movement, whereas the corticospinal tract is all about speed. Get it done. All right, the white matter of the spinal cord, we have 3 major fasciculi. We're talking largely here about the ascending pathway, so these are going to be more afferent. So we've got the dorsal, lateral, and anterior fasciculi. So they're coming from the body up to the brain. We're sensing pain, touch, temperature, etc. So our ascending pathways are afferent. Got some alliteration to help you remember there. Or sensory. All right, so the dorsal pathway in the back of the spinal cord, that's your fasciculus gracilis and fasciculus cuneatus. So that's our fine touch discrimination, and again, very fast transit. And the fasciculus gracilis brings information from your lower extremities. You can think about walking gracefully. You can't do that if you don't have information from the fasciculus gracilis, if you're walking on gravel versus ice versus grass, etc. And then the fasciculus cuneatus brings the epicritic information from your upper extremities. And so I always think about biting my cuticles or writing cuneiform script, but that's fasciculus cuneatus, gives you that fine touch, that fine discriminate touch. And then our lateral ascending pathways, we have spinocerebellar tracts. We have the anterior spinocerebellar tract from the lower extremities in the trunk, and the posterior spinocerebellar tract from the upper extremities and the joints. And that's unconscious proprioception, so kind of where we are in space. Are we upright? Did we just bust our butts and we're horizontal? What's going on? And then the anterior system is largely your anterolateral system, spinothalamic tracts. So we have anterior diffuse touch, backup sensory information, and the lateral portion is for pain and temperature sensation. So touching the stove, there's your pathway. All right, so now we've talked about the cortical structures and our subcortical structures, and we talked about our pathways, our descending pathways. So the descending pathways fire on the peripheral nervous system, and the portion of the peripheral nervous system that we're most concerned about are the cranial nerves. So we have 12 cranial nerves denoted with Roman numerals. They're all involved in speech and swallowing to some degree, or cognition if you want to think about it that way. But olfactory is critical for taste. It's chemosense related to our sense of taste. And it's also important for memory. Then we have the ones in yellow have for vision and reading, for reading comprehension, reading nonverbal cues and facial expressions. And then we have the ones in bold white that are important for speech and swallowing specifically: trigeminal, facial, glossopharyngeal, vagus, accessory, and hypoglossal. The acoustic nerve is in red. It is both motor and sensory for hearing and balance. And of course we have the OAEs, the otoacoustic emissions, which is a diagnostic criteria that measures the efferent pathways of the inner ear. All right, so we have 4 cranial nerves that help innervate the tongue. 3 of those are sensory, and 1 of those is motor. So the trigeminal is just the tactile sensation for the anterior 2/3 of the tongue, tactile and taste. And then the facial nerve is taste. Oh, wait, did I say that? I said that wrong. I apologize. Tactile and temperature for the anterior 2/3 of the tongue. And then the facial nerve is the sensory for taste for the anterior 2/3 of the tongue. I apologize. And then, of course, it innervates the facial muscles, so that makes it both motor and sensory, facial muscles, and then taste for the tongue. Glossopharyngeal is both as well, innervating the muscles of the pharynx, and then being sensory for the posterior 1/3 of the tongue. And it's sensory for everything, sensory for taste, touch, temperature, etc. It does all, it's a one-stop shop for sensation of the back of the tongue. And then the vagus nerve, we're going to hit on it again when we do the laryngeal system, but it is both motor and sensory, especially for the larynx. And so when you think about the vagus, it innervates the majority of the velum and the larynx. So I always tell my students to remember voice, vagus, velum, or velum, vagus, voice. So it's critical for resonance, for phonation, and swallowing. And then we have the accessory cranial nerve that innervates the neck muscles. And then cranial nerve 12, hypoglossal, critical for articulation because it innervates our tongue muscles. All right, so all those tongue twisters, if you've ever read "Oh Say, Can You Say?" From Dr. Seuss, you're really working cranial nerve 12 there. Okay. The meningeal layers are non-neural connective tissue that protect the brain. You've got three main layers: the dura mater, the arachnoid layer, and then the pia mater. And the dura mater is the outermost layer of the meninges, and it's tough and durable. It looks kind of like wax paper, but you can't stretch it or tear it. It has to be punctured with a really sharp tool like a scalpel. The arachnoid layer is the middle layer, and it is called that because you can see the veins underneath it because it's more transparent. And then, so it looks like spider veins, kind of, that's where it gets that name. And then the innermost layer is the pia mater, and that means little mother, okay? And so if you think about your mother, she can be fierce mama bear when she's protecting you, tough and durable. And then she's also got that tender heart for her baby girl, baby boy, right? When she hugs you close and hugs every nook and cranny, and that's the pia mater. It hugs the brain really close and keeps it encapsulated, and it sits, it adheres to the surface of the cortex and is the innermost layer of the meninges. All right, so the circulatory system of the brain, okay? So we're coming off the heart, and we're traveling up the carotid arteries, up the neck, and we come to the base of the brain. We come up the internal, or the carotid artery anteriorly, and up the back we come up the vertebral arteries. I apologize, kind of got distracted there. And the vertebral arteries ascend through little holes in the cervical vertebrae, and then they merge in the back of the neck and the base of the brain here into the basilar artery. So we have vertebral artery, and they merge into the basilar artery that runs up the brainstem. And then they contribute from there to the circle of Willis, right? And then the blood coming from the front to the front of the face and the front of the brain, come up with the carotid, and then ultimately the internal carotid when it branches, and also connects to the circle of Willis, and then travels up the anterior cerebral artery. So your circle of Willis is kind of like a traffic circle or a traffic loop in a big city. I know Louisville's got a couple. I know Nashville's got a few of those. Even Jackson has a portion of one. Jackson, Mississippi, where I live. But these are, if you think about traffic loops in a city, it's a portion of the interstate that goes all the way around. And so instead of having to take the streets, you can get on and go 65, 70 miles an hour, however fast, or HOV lane. It helps you get around the city faster. And so your larger cities that have had the sprawl, sometimes you'll have more than one traffic loop to accommodate the sprawl, right? And so but the way that works is if there's a wreck ahead, you can get off on an exit and still get to your destination. Or if you miss your exit, you can go to the next exit and backtrack and get where you're going. And that's kind of what the circle of Willis is. It's kind of a protective mechanism in the base of the brain, and the blood can circulate around, and if there's an occlusion up to that point, the brain can still receive blood from the rest of the circle of Willis. The pressure may be a little altered, but it can still receive the blood and keep the constant supply of glucose and oxygen that the brain needs. So the anterior cerebral artery brings blood to the medial frontal lobes. Middle cerebral artery, this is the one that's most critical for our stroke patients the majority of the time, especially those with aphasia. That left middle cerebral artery feeds the lateral portions of the frontal, temporal, and parietal lobes. And so if they have a lesion right about here in the middle cerebral artery, can you see? Let me change colors so you can see it better. If we have a lesion here in the middle cerebral artery, a lot of times they call that the watershed area because it's at the base of the middle cerebral area before it branches off and really provides blood to the distant regions of the frontal lobe and parietal lobe and temporal lobe. It's also where, if you remember right there, where all your language areas are kind of located, and so it can be really devastating from a linguistic perspective. And then your posterior cerebral artery provides blood to the medial temporal and occipital lobes, and basilar artery gives blood to the brainstem and circle of Willis. Okay. All right, so that's all we're going to do for the nervous system for now, which was pretty thorough for the short amount of time we spent on it. But it ought to get the cobwebs cleared out and you can figure out what you need to go back and review. All right, next up, we got the respiratory system, the power source for speech. So respiration in and of itself is just the gas exchange between an organism and its environment. So our respiration system is much different than a fish's, right? Inspiration is bringing air into the lungs, or inhaling. Expiration is a process of removing air from the lungs, or exhalation. Okay, so inhalation is largely a product of movement of the thoracic muscles, and exhalation is largely passive. There's not a lot of muscle activity, especially if we're doing tidal breathing. Tidal breathing is just when you're sitting there breathing at rest. You're not talking, you're not exercising, you're just existing. So the air comes in, the air goes out like the tide, okay? Ebb and flow. And we'll talk about the breathing cycle with tidal breathing is much more equal. It's like a 40-60 ratio. Whereas with speech breathing, we'll talk about checking, and that's the process that allows us to control or impede the release of air during speech exhalation. And so again, we're not really using muscles to control that release of air. It's not contracting the muscles to squeeze the air out. It's a controlled release, kind of like a check yourself before you wreck yourself, right? If we did this a little bit better, we wouldn't stick our feet in our mouth so much because we wouldn't have the air to say the things we want to say. But this shows you the difference between the muscles, especially for inspiration. So we have all these thoracic muscles, and you'll notice that the diaphragm's included. We have neck muscles. And then the expiration muscles that we've got listed, notice largely during forced exhalation. So if you're really trying to belt out a word, or if you're coughing, then these come into play, right? Because if you've ever had bronchitis, you know your abs can be sore from coughing. So the tidal breathing, when we inhale, the rib cage expands, the diaphragm contracts, increasing the volume of the thorax, and air rushes in. And so, again, with tidal breathing, the inspiratory and expiratory cycles are almost equal. It's about 40% inspiratory, 60% expiratory. And the exhale is going to be passive. It's recoil and gravity, and then the surface tension of the alveolar lining within the lungs. But with speech breathing, we have a short inspiratory cycle and a long expiratory cycle because we're using that controlled exhalation. So if we were going to draw it, let's see here, our tidal breathing would look kind of like this, pretty equal, right? Whereas our speech breathing would look more like this. So it's a quick inhalation, so a steep slope up, and then a gradual slope down as we control that exhalation. Our respiratory measures, we've got quantitative volumes. So this is largely what pulmonologists and respiratory therapists are looking at. How much air can we take in? How much air do we need to maintain the oxygen levels? But what we usually use are our capacities, and these are functional measures. And the vital capacity is the one that's critical for speech. So that's the sum of your inspiratory reserve, your expiratory reserve, and your tidal volume. So these first three here are summed up to create the vital capacity. All right, moving on up. Literally. To the larynx, we've got your vibratory sound source. And that's what we care about as when it comes to voice, but it's also very important for swallowing because it's critical for airway safety, and it protects the airway during swallowing because the vocal folds don't just close when we're speaking. That's when they're vibrating, but they just close and stay closed during swallowing, during the swallow apnea. Okay. So with this picture, we got a picture of largely the cartilages of the larynx and a few of the muscles. Let me turn my pointer on. Oh, shoot. No, okay, I think that's all right. But we have the thyroid cartilage, of course, is the biggest here. And there's your thyroid notch. That's what you feel in your neck when you swallow. That's your Adam's apple. And then up here we have the hyoid bone from which the larynx is suspended. And this is what we're looking for in a MBS. We look at hyolaryngeal excursion. We want to see that hyoid bump up toward the mandible. Because when it bumps up toward the mandible, the whole larynx goes with it and gets the airway out of the way for the bolus to go safely into the esophagus. Posteriorly, you can see how much bigger the cricoid cartilage is in the back. It's much broader in the back and more narrow here in the front. And you can see the PCA, the only abductor or opener of the vocal folds. It's kind of hard to see. You might want to look a little more closely at the picture in the book. But you've got your transverse arytenoids and your oblique arytenoids, and then your LCA more laterally over here. And the LCA and the PCA have an agonist-antagonist relationship for swiveling the arytenoid open, and thereby the vocal fold open and shut. All right, so our suprahyoid muscles are our laryngeal elevators. We've got the digastric, more specifically the anterior belly of the digastric. We've got mylohyoid, geniohyoid. These are three primary elevators for swallowing. With your mylohyoid generally pulling the larynx directly up, and the geniohyoid pulling the larynx anteriorly toward the hyoid. And this is the plane that most MBSs are in. So the geniohyoid pulls the hyoid anteriorly toward the mandible. The stylohyoid, hyoglossus, and genioglossus are also contributors to laryngeal elevators. And you'll notice the hyoglossus and genioglossus are also extrinsic tongue muscles. And then thyropharyngeus, there's debate about it, but it constricts the pharynx and does contribute to some elevation of the larynx. All right, so this picture shows a better relationship of the tongue because we talked about the genioglossus here and the hyoglossus. Then we have the geniohyoid, and you'll see like they've taken off the mandible off this model, but the genioglossus inserts directly into the mandible right here at this anterior point. Okay, and then you have your mylohyoid that also inserts here, but it's a broad muscle that goes along your jaw line laterally. And so that geniohyoid goes from the mandible in front to the hyoid back here. Okay, so it extends here. So when it contracts, it makes sense that it's jerking it forward. Okay, or this geniohyoid, since this one kind of goes the direction on the previous slide, when this muscle contracts, it's pulling the hyoid toward the mandible. Okay. Whereas the mylohyoid, again, it wraps around along the jawline, and so it's kind of like a basket. Like if you were lifting the hinge. Oh, let me think. That's not a good one. Like a sieve, you'd be lifting the whole thing, not just anteriorly. It's just pulling it straight up, like if you were, I know I'm out of analogies. Stop talking. And then on the side here, we've got the thyrohyoid muscle. And you can see when that contracts, it's definitely going to pull the thyroid muscle toward the hyoid. Then you can also have a good view of the thyroid cartilage and the cricoid cartilage, and then the tracheal rings anteriorly. Our infrahyoid muscles, this is one you'll see every now and then on the praxis, kind of as a, are you really paying attention? But if you see anything that doesn't say thyro really in it, or genio or myelo, those are all, genio and myelo, of course, are specific to the mandible. But sternohyoid is coming off the breastbone, off the sternum. Omohyoid's coming off the scapula, so from your shoulder blade. And then sternothyroid, again, sternum to thyroid cartilage. And thyrohyoid, that's a muscle that's kind of tricky because it can pull the hyoid down, or it can pull the thyroid cartilage up. And so you got to kind of know which one's being anchored. But again, these are inserting to the hyoid bone and thyroid cartilage from below. And so when they contract, generally they're going to pull it down. Okay. So these would not be targeted in dysphagia treatment at all, because we want to lift the larynx, not pull it down. This does have some intrinsic laryngeal muscles in it, because it shows you here the true vocal fold, and of course that the most medial muscle there is thyromuscularis of your cricoarytenoids, and you can see the mid-sagittal view of the transverse arytenoid here, and it's the first to contract when it comes to adducting or closing the vocal folds. Okay, so your true vocal folds, your inferior and most medial set, are made up of different layers of different types of tissue and different densities. The outermost layer is your epithelial layer and your superficial lamina propria. Then we have the intermediate lamina propria and the deep lamina propria, and they're getting denser as we get deeper. So I always think about a bed. That top layer is really loose and soft and bouncy, right? That's how we get the mucosal wave, because all the fibers are really elastic and spread far apart. And then we get a little deeper, we get a little denser. Is that right? So that's maybe your actual mattress. And then the deepest layer, the thyroarytenoideus muscle, more specifically thyrovocalis, is really dense, right? Those fibers are really tightly packed and different type of, striated muscle, very different than epithelial tissue. On the next thing I'd like to show you here, with this axial view of the vocal folds, remember you've got two thyroarytenoideus muscles. So in blue, you've got your thyrovocalis, and that's the deepest layer of the vocal folds, right? That gives the vocal folds their stiffness. And then laterally, you've got the thyromuscularis, and it is one of your relaxers, your vocal fold relaxers. And so you've got an agonist-antagonist relationship between thyrovocalis and thyromuscularis as they tense and relax the vocal folds for different sounds or inflection, as in conversational speech. I think that's all I want to show you. Yeah, so those are your thyroarytenoideus muscles. We were talking about abduction and adduction, so these vocal folds are abducted because you can see the glottis. Now, when we want to phonate, the transverse arytenoideus muscles, they run horizontally, they contract first, pulling the bases of the arytenoids to the midline, right? And then we have the oblique arytenoideus muscles that crisscross from the base of one arytenoid to the tip of the other, and they bring the tips of the arytenoids together, bringing the vocal folds closer together. And then you have the LCA, let's use a different color. You have the LCA out here contracting to swivel the arytenoid process completely shut. So it goes transverse, obliques, LCA. but they fire pretty rapidly in rapid sequence to close the vocal folds for phonation, for that initial closure. And then the aerodynamic principles blow them open for the vibration. I want to be clear about that, because we can't volitionally open our vocal folds that fast. Kind of like doing this with your lips. So I've got my lips shut, but I'm blowing the air through them. And that's what's happening at the level of the vocal folds, right? The transverse arytenoideus muscles, the obliques, and the LCA are holding them shut. And the aerodynamic principles and Boyle's law and the Bernoulli effect are blowing the air through the vocal folds so that they're creating a vibratory sound that we shape into speech. All right, thank you. Yeah, okay, I said that right. All right, so thyrovocalis is the most medial muscle, and so in the layers of the vocal fold we're just looking at, that's really thyrovocalis. And it is the tensor, and it's the most medial of the cricothyroarytenoideus muscles. And then we have PCA, which is your only abductor, so it's critical for respiration and survival. And then the LCA is one of the adductors, and then our arytenoideus muscles are critical to adduction, airway protection during swallowing. Transverse arytenoids and oblique arytenoids. And then over here on the right, I have them classified by function. So abductors, just your PCAs, paired muscles. Your adductors, your LCA, and then your transverse arytenoideus and oblique arytenoideus. Your tensors are your cricothyroid and thyrovocalis. They raise the pitch. And our relaxers are thyromuscularis and your LCA. There they are again, and that has the origin insertion. Different people learn the muscles best in different ways. So I've got them listed by name, by function, and then in tabular form. All right. So we said a true vocal fold has a vocal ligament, thyrovocalis muscle, and thyromuscularis muscle, and layers of tissue. And those layers are the cover, which is the epithelium, and the superficial layer, the lamina propria, the transitional layer of intermediate and deep layers of the lamina propria, and the body, which is the vocalis muscle. So again, the cover is the loosest layer and the floppiest layer. That's what gives us the mucosal wave. And then it sits or rides on top of the transition layer, and then the body is the vocalis muscle, and that's the densest layer. Healthy vocal folds should be a pearly white and look kind of wet and have a mucosal wave if we're doing stroboscopy. All right, laryngeal innervation. We said that vagus nerve is for voice or phonation. We've got the superior laryngeal nerve that's critical for sensation in the supraglottic space and your cough reflex. But motorically, it only innervates the cricothyroid, the major tensor of the vocal folds. The recurrent laryngeal nerve has two branches, and the inferior branch of the recurrent nerve innervates all of the other intrinsic laryngeal muscles. And so it's important for opening and closing the vocal folds. The image on the right shows you the vagus nerve coursing down the side of the neck, and then the recurrent branch looping under the aorta and back up to the larynx. And this is a picture of the left vagus nerve, and there are different reasons for that, but the great thing about this picture will help you remember that the left vagus nerve, and we always look at the left side of the brain because it's responsible for language, so left vagus, left hemisphere, language, all this goes together. But the number one cause of unilateral vocal fold paralysis is damage to this recurrent laryngeal nerve, okay, especially that inferior branch of the recurrent laryngeal nerve. Just because any type of cardiothoracic surgery often causes trauma to this. It's an iatrogenic cause of vocal fold paralysis, but it's the number one traumatic cause of unilateral vocal fold paralysis. All right, so our speech production process is interdependence of laryngeal anatomy, physiology, neurology, and acoustics. We have predictable changes, and it's based on the myoelastic aerodynamic theory. So myo is muscles. Elasticity is the elasticity of the tissues, that whole body and cover we were just talking about, and the flop and the mucosa wave. And then the aerodynamic principles that support it. Boyle's law is that the air is always going to seek an equilibrium, and the Bernoulli effect is a vacuum. And then we have subglottal air pressure needed to put all this into play. And so the subglottal air pressure needed for typical speech is 3 to 5 cubic centimeters. All right. So the speech production process is based on that the myoelastic aerodynamic theory. So the myo part of it, the vocal folds adduct due to contraction of intrinsic laryngeal muscles, specifically contraction of the transverse arytenoideus, the oblique arytenoideus, and then also your LCA, the lateral cricoarytenoid. When the vocal folds are fully approximated, when they're all the way in the middle, the subglottal air pressure is increased compared to that above the vocal folds, compared to the supraglottal space. That increased pressure causes the vocal folds to blow open from bottom to top, and it blows them open very briefly but completely. And while they're open, that changes the velocity of the airflow between the vocal folds, and that pressure differential causes a vacuum, or the Bernoulli principle. It's kind of like when you're driving a small car you're trying to pass a semi, and your wheelbase is much narrower than the wide wheelbase on the semi, and it kind of pulls you toward them. That's the Bernoulli principle, and that's what's going on at the level of vocal folds. That decreased air pressure and elastic recoil of the tissues pulls them back to the midline, and the vocal folds approximate inferiorly to superiorly, eventually closing completely. And that's just one cycle. That's just one cycle of vocal fold vibration for phonation. So that has to happen over and over and over, 100 times for an adult male, 200 times for an adult female, or 300 to 500 for a baby or an infant, right? Because adult females generally vibrate around 200, 230 hertz. Adult males 100 to 110, and then children 300 to 500. All right, so laryngeal physiology. So all these principles. The best way to think about pitch, in my opinion, is think about a rubber band or the strings on a guitar or a piano, because the thinner the string and the tighter the string, the higher the pitch. But the fatter the string and the more relaxed the string, the lower the pitch. Okay. Loudness is a function of the pressure and then the degree of resistance. So the more subglottal pressure we have, the higher the intensity. So that's why I keep talking about the respiratory system being our power source, because the bigger breath we have, the louder we can get. But if we force our vocal folds closed for a longer time, that's going to build up pressure too. And so if you think a lot of people with vocal abuse, they really close those vocal folds really hard and increase that resistance for to get loud. And then quality is the unique perceptual characteristic of voice. Spectrum is the best acoustic correlate we have of vocal quality, but it's highly dependent on the shape and configuration of the vocal tract. All right, for swallowing, we have 4 main phases. We have oral prep, oral transport, pharyngeal, and esophageal. Oral prep and oral transport are largely under voluntary control. Oral prep, we're salivating, we're chewing, we're forming a cohesive bolus. Transport, we're shoving it to the back to our throats, and our swallow reflex is triggered when that bolus reaches the valleculae. In the pharyngeal phase, this is where airway protection happens, okay? So we have constriction of the pharyngeal walls, pushing the bolus down. We have adduction or closure of the true, false, and aryepiglottic vocal folds. We have elevation and anterior movement of the hyoid and larynx, Thank you very much to the mylohyoid and the geniohyoid. They contribute to that. We have tongue-based retraction that helps push the epiglottis down. And that's why I've got the epiglottis starred here. It doesn't really move all by itself. It's kind of more a passive participator or participant. But you've got the hyoid kind of knocking it, because the hyoid is pulling the larynx up, and so it's kind of knocking the feet out from under the epiglottis, and the tongue is pushing it down from the top. So it's getting kind of a double teamed, if you want to think about it that way, to get that epiglottic inversion. And then also in the pharyngeal phase, we have the opening of the pharyngoesophageal sphincter, or the UES, upper esophageal sphincter. When the bolus passes through the upper esophageal sphincter, we have the esophageal phase, where we see peristalsis, or the rhythmic sequential wave-like constrictions or contractions that push the food down toward the stomach. Okay? So that concludes our vibratory sound source / swallowing section. And now we're going to do our articulatory system, which is largely based on the source filter theory of sound production. Again, respiration is the power source. Vocal folds are the vibratory sound source for voiced phonemes only, right? So all of our vowels and about half of our consonants. And then the vocal cavity changes the shape of the oral, pharyngeal, and nasal cavities and the degree of coupling to shape and create the phonemes. And so this is just one way, or the main way we think about articulation. All right, so the air comes up. Where are we? The air comes up from the trachea through the larynx, create a vibration, and then the air either travels out the mouth for oral sounds or out the nasal cavities for nasal sounds. And then the tongue can move in all different directions. Remember, it's under fine motor control, lots of neurons dedicated to it in the cortex for that fine control that we need for speech sounds. These are the muscles of the face and the related structures. Orbicularis oris is what we think of as our lips largely. Risorius and buccinator or buccinator pull the corners of the lips straight back. They're horizontal or transverse muscles. Zygomatic major is the major muscle of smiling. And mentalis is the major muscle of pouting. And we're going to talk about the tongue a little bit more. But this is a synopsis of, or summary of, all the muscles of the face and articulation and resonance to a degree. All right, so our mandibular muscles, I'm specifying them because they're critical for speech, because if you don't open your mouth, then it sounds kind of funny, right? But if we open our mouth, it helps our articulation and our resonance. And it's also important in chewing. So we've got temporalis and the masseter right here that anchors right up under the molars and gives you the really force of that chewing, of the hard chewing and grinding of those molars, grind up meat. And then if we look a little more, here we can see the temporalis and where it inserts on the other side. And then if we remove the masseter and the temporalis, we can see the pterygoid muscles. And they help with opening and closing, and also the lateral action that gives us the rotary chewing that we see in a typical adult pattern of swallowing or mastication. So our intrinsic muscles of the tongue, we have a thin layer of muscle, just deep. So this is just deep to the mucous membrane of the tongue, and it shortens the tongue and turns the tip up. So that's going to be critical for making sounds like t, s, and l, and n, right? And then the oblique fibers turn the lateral margins up. And so that would be like for and ch, all those kind of fun sounds. And then our inferior longitudinal muscles shortens the tongue or pulls the tip down. So that way we need that for the ah sound. Transverse runs laterally toward the margin of the tongue and narrows and elongates the tongue. So when you want to stick your tongue out at somebody, you're really, the transverse one is helping with that, in addition to some extrinsic muscles. And then our vertical fibers originate in the dorsum and run down, they run up and down from the front of the tongue to the back of the tongue. And they flatten the tongue. So they're also going to be important for ah, because on ah, your tongue tip is down, but the entire tongue is also flat. And so the vertical muscles are critical for flattening your tongue. All right, so there the intrinsic muscles are again. Again, some people like it better listed, some people like it better in tabular form. And then our extrinsic muscles of the tongue: genioglossus, styloglossus, palatal-glossus, hyoglossus. Two that I'm going to point out just real quickly. Genioglossus is the primary mover. So when we're talking about protruding the tongue a second ago, the transverse muscle is going to narrow it a fair amount, but the genioglossus is the primary mover, really gets the tongue out. So think about Mick Jagger, or you may have to ask your mother or your grandmother who that is, but he always used to stick his tongue out all the way. And so he was getting great use of his genioglossus. And then also palatoglossus, that is a muscle that goes from the soft palate to the back of the tongue. And it's important for tongue movement and velar movement, but it also forms the anterior faucial pillars, which is a landmark in the back of the oral cavity. The palate is critical for coupling, or the degree of coupling between the nasopharynx and oropharynx. A lot of times this will be on the praxis, but 75% of the hard palate, or the palate, is formed by the palatine processes of the maxilla. So 75% of the hard palate are the maxillary bones, and 25% are formed by the palatine bones, and that's the most posterior 25% of the hard palate. Landmarks that we see on the hard palate are rugae, the midline raphe, and the torus palatine. Some people have that in the center. The palatal vault can impact resonance, especially the palatal height. Some people have a very high, narrow palatal vault, and their speech sounds different than somebody has a lower one. The ear we'll cover just real quickly. It's housed in the temporal bone and the petrous portion of the temporal bone. It's considered a major energy converter. We have three sections: the external or outer ear, middle ear, and the inner ear. And each of these sections have a different medium and a different function, right? So the external outer ear is air-filled, and it's collecting, directing, and localizing sound. So it's acoustic energy. The middle ear is air-filled still, but it's encased, right? It's not open to the environment. And so that's where our ossicular chain is, and it's going to change that acoustic energy from the eardrum to mechanical energy as the ossicular chain swings. Then we have the inner ear, which is fluid-filled, and the mechanical energy as the stapes is bouncing against the oval window. That mechanical energy is transduced to fluid or hydrostatic energy, and then ultimately into an electrochemical signal that the brain can understand, because that hydrostatic energy triggers the hair cells that fires on the neurons. Okay, so this is a picture that kind of shows what color have I got highlighted. That's not going to help. Okay, so we get all the way here. All this is the outer ear, right? Air-filled, collecting and directing sound toward the tympanic membrane. And all of this is the middle ear. And then you see that stapes footplate, and it bangs on that oval window and sends, it's kind of like thumping a bowl of jelly, and it sends a wave through the cochlea, through the fluids of the cochlea. And so this picture, these images also demonstrate that. I like this because it kind of also shows, how the sound wave is traveling, and you just kind of have to remember that this part is in the middle is mechanical energy. So we go from acoustic energy out here to mechanical energy here, and here we have fluid energy, because this is a fluid-filled cavity, hydrostatic energy, okay? And so that wave travels all, let me give a pointer on, that wave travels all the way up that spiral staircase and all the way back down. Peripheral hearing, this is in 8 steps. It also, these 8 steps are also correlated with different diagnostic or auditory evaluation to determine type and degree of hearing loss. So first we have the outer ear collecting sound waves and funneling to the tympanic membrane. Second, tympanic membrane absorbs the sound waves and passes that energy to the ossicles. Ossicles amplify and concentrate the sound. That's the lever principle and surface area ratio. That stay-piece footplate rocks in the oval window, thumping that bowl of jelly, sending the vibrations into the cochlea. Fifth, the vibrations go from the stay-piece all along that basilar membrane, peaking at the frequencies that go with the sound that was received. Sixth, when we reach that point of maximum vibration, the outer hair cells tuned to that frequency receive that sound and amplify the traveling wave sharply so that we stimulate the hair cells. So seventh, that action of the amplification triggers the hair cells because of that movement of the tectoral and basilar membranes, and stimulates dendrites at the bases of those cells. And then eighth, the dendrites of the 8th nerve fibers generate an action potential to travel up to the brainstem. And so, again, this kind of has sound wave in the outer ear. Sound wave in the outer ear, hit that tympanic membrane, set the ossicular chain in motion. We have mechanical energy, movement, and now the stay-piece is thumping this bowl of jelly, and now we create a wave. And you've got this, the basilar membrane, think of it as like a diving board, right? And so if you're on a diving board, when you're on the when you first take a step onto that diving board, it's pretty rigid. You don't get a lot of bounce there. But if you move out to the tip, it's a lot floppier out here, so you get more vibration. And so, depending on the bounce you want and whether or not you want to make it into the water, you got to jump pretty hard and launch yourself pretty far if you're farther back on this membrane. But, the sound waves are going to be, they're tonotopically organized, the hair cells along here. And so when the sound wave hits, so if we have 100 hertz sound, it's going to only fire where the hair cells are trained for 100 hertz. And generally, high frequencies are at the bottom and low frequencies at the top. Central pathway for sound, 8th cranial nerve to the medulla, to the superior olivary complex. And this is where first comparisons are made for timing and intensity. It helps us with location because our ears don't move like horses and dogs. Then we go to the lateral lemniscus, the ascending pathway from the medulla to the midbrain. Then we go to the inferior colliculus of the midbrain. We get information about angular sounds and integrate it with visual and other sensory input. Then we go to the medial geniculate body of the thalamus, which helps relay the information to the Heschel's gyrus and the cortex, and then ultimately to Wernicke's area. So we don't hear in the cochlea, we hear in the brain. Distinctive features of the auditory system: we have bilateral auditory representation, 2 Heschel's gyri, that's what they're saying there. Sound source location, or to be clear, you have a Heschel's gyrus in your right temporal lobe and your left temporal lobe, because you've got two cochleas with two sets of hair cells. And remember, we said we had a one-on-one relationship with hair cells and neurons in the in Heschel's gyrus that are also tonotopically organized. Sound source location is determined by interaural, so they're comparing the differences in the timing and loudness of the sound between the ears. Tonotopic organization is maintained from the cochlea all the way up to Heschel's gyrus. And then the descending auditory projections, efferent fibers from the cortex, extend back to the inner and outer hair cells within the organ of corti and the cochlea. And these help sharpen perception by suppressing competing signals and improving sound location to keep us safe. All right, if you have any questions, please jot them down and come in for office hours in a couple weeks, that first week in October, and I will do my best to clear things up for you, and we'll do some review questions as well to practice on these topics, and we'll figure out how to navigate some of the terminology used in the questions. Thank you for your time, and can't wait to see you in a couple weeks. Okay.